Into insulin therapy. So we've discussed oral agents that can be used and how they can be used in combination. Now we're going to talk about insulin therapy. And insulin commonly is used in combination also, particularly now because of what we're trying to do in the absence of insulin production. So remember, a majority of the time, there are some type 2 diabetics that do take insulin, but a majority of the time when we're talking about insulin therapy, we're talking about type 1 diabetics, and that's the context I want to provide. And then that will kind of help you give you the parameters of the way we use insulin therapy so that when you move out into the clinical environment and you see patients who are type 2 diabetics, you see them on insulin, you can understand perhaps the complexity of what's happened to try to get to the place to manage their diabetes to the point that now we have to do insulin therapy. So that reflects a degradation of the type 2 diabetics condition. So I just want to point that out. So now, in the context of type 1 diabetes, as I've said before, a cornerstone here is going to be self-glucose monitoring. So these patients have got to be doing self-monitoring of their glucose in one way or another. So preferably they're doing finger sticks. If not finger sticks, they're using the devices. I point to my shoulder or arm because I see that's where a lot of people wear them. You can wear them on the abdomen, but they communicate with the smartphones. These are great tools to help people easily keep a check of their glucose. Now, when we're doing a finger stick or these subcutaneous devices, what we're measuring there is plasma glucose. We're doing serum when we draw blood. So it's good to know that distinction, but ultimately what we want is we want those results consistent with each other. So most patients are going to be doing plasma glucose monitoring from those Bluetooth devices or from finger sticks, preferably. Now, the couple of reasons why this is so important. One is because we want to be diligent, as we've talked about already, of making sure the glucose is staying in the range we want it in. And we want to avoid complications such as hyperglycemia and hypoglycemia. As I mentioned before, hypoglycemia can definitely kill you. Hyperglycemia, if bad enough, can also kill you, and we're going to talk through that. Now, what is important is that patients are doing this on a routine basis with some sort of predictive schedule, even when they're sick. It's even becomes more imperative when these patients get ill with things like the flu or strep throat or a tooth infection or a urinary tract infection or yeast infection, whatever it might be, because those infections then alter the way the body responds in the metabolic need for glucose and the way the patient feels about eating. So obviously patients can develop nausea and vomiting, and that alters carbohydrate consumption, and patients still need insulin. So there are essentially 4 categories that I've listed for you here that constitute the types of insulin. That's rapid acting insulin, short acting, which is regular insulin, intermediate acting insulin, which are medications like NPH. There's also 70/30. You don't see that much around anymore, but you may see it on occasion. And then very long acting, which are the peakless insulins. We're going to talk about each of these as we move forward. So this slide gives you a grouping. I have a few slides here to kind of begin to paint in your mind a picture of how these insulins work. And then we'll talk about the rationales for why they're designed to work as they are. So short-acting insulins are insulins such as aspart, glulisine, Lispro, and regular insulin. And here you see their onset, their peak, and their effective duration. So you can see why there's a slight distinction for the onset for regular insulin from the others, but I'm not going to be that particular about that. There are some distinctions about regular insulin that I'm going to point out that I want you to know, but whether it's short or immediate acting, that's not so imperative. But what I want you to see is that these insulins are designed to have a very rapid onset within a quarter to half hour, and then peak somewhere between 30 minutes to 2.5 hours, and have a duration somewhere in the 2 to 6 hour range. That's what I want you to see for these insulins. These insulins are designed to address peaks in glucose, right? So think about when you eat. When you eat, there is a surge of glucose in your system, and you have to have a peak of insulin that's comparable to that peak of carbohydrate consumption. And that's what these insulins are designed to address. Then you have longer acting insulins such as detramer or glargine, which, as you can see, those two, they really don't have a peak there. These are the ones we refer to as peakless. These insulins are designed to mimic the action of your pancreas over time. So if you were to be fasting, for example, if you or I were to be fasting, we would still have insulin released throughout that 24-hour period of fasting, because we have a basal rate of insulin. And even between meals, we have what constitutes a basal rate of insulin. And then with each meal, we have a peak. These long-acting insulins like detramer and glargine are designed to be that peakless but constant dosage that's provided through the 24-hour period. So they do not provide this rapid, they do not address these rapid onsets of high glucose. NPH is a long-acting insulin. You notice the onset 2 to 4 hours, and its peak time is somewhere between 4 to 10. So it's way out there as far as its peak. But the point is, NPH insulin does have a peak, whereas detramer and glargine do not. So in this particular slide, when you think of peakless, think of those first two, and long-acting would be NPH. You may also see things like the 70-30, the 70% protamine, 30% aspart, or the 70% NPH, 30% regular. You may see those out there. They also have the effect of having a peak onset shortly on, and then providing long-term coverage. So they're trying to, in one suspension, have the effect of two different types of insulin. We'll talk about insulin regimens in a little bit. This slide is just intended, I've got two picture slides to show you different ways to visualize the rapid onset insulins compared to short acting, compared to immediate, compared to long acting, and then ultimately to the peakless or very prolonged acting insulin. So this shows you where the peaks happen and how they're designed to work over time. And in class, we'll talk in detail about what we're trying to accomplish with these different insulins here. So this slide also shows you that this you have this immediate onset of things like Lispro, aspart, or glargine, glulisine, and then the short-acting regular insulins that address if we need to do some correction coverage because of how many carbohydrates are in a patient's meal, or if they've spiked at lunchtime right before lunch, we need to get ahead of the game. So we may do a short-acting insulin before they eat. And then you have the intermediate acting and the long acting or peakless. So I think this slide is the best place to pause for a moment and show you kind of how these insulins are designed to work, what we were trying to accomplish. So these, as I mentioned before, if you have a 24-hour period here of this person's life, in between there are going to be meals that create a spike in carbohydrate levels in the patient's bloodstream, definitely related to food consumption. So back in the day when insulin was first developed, all we had was regular insulin. That was the first insulin that was isolated, and that's what we used. So what we would try to do is coordinate these peaks throughout the day with when we thought the patient was going to be consuming or needing coverage for the for their carbohydrate consumption and try to perhaps do multiple injections through the day. Well, scientists developed NPH, 70/30, these medicines that have a longer time of action, and depending on the mixture could have a short onset and then a longer duration. So what they're trying to accomplish is think about time zero being when the patient wakes up in the morning. So the patient wakes up in the morning and they haven't eaten overnight. So they're going to be eating breakfast shortly. So they're shortly going to need some insulin. And we would love, as I mentioned before, to be able to do one thing and it worked for the whole 24-hour period. So that's why they developed these intermediate acting and these combinations of insulin so that the patient could inject. They would get the immediate onset that would address them consuming breakfast, but then this longer peak would last throughout the daytime period. So if you see a 5-hour lapse, a 10-hour lapse, by the time we get out to 15 hours, we're getting into the period of time where patients are going to be heading to bed and not eating. So these intermediate acting insulins were designed to provide coverage through the day in a higher level as they're eating lunch and dinner and snacks, and then as the evening onsets and they head to bed, when they're not consuming, that insulin's pulling away. So we don't have people having hypoglycemia in the night when they're not eating, and they're not having hyperglycemia during the day because we've got these insulins covered. That was why these intermediates came into development. Well, that worked some, but there are some patients who needed better management. And so these peakless insulins have been developed more recently that provide, as I mentioned earlier, a basal coverage of insulin through a 24-hour period. So there's really not a peak. They gradually increase in the morning, as you can see in this slide. And then as patients eat through the day, we might do smaller doses of the short-acting or rapid-acting insulins to address meal times. That's what we refer to as carbohydrate coverage or correction dosages. So if a patient has a peak right before lunch, they may do a correction dose, and then they may cover the carbs that they're about to eat in their meal with a short-acting insulin. So that's more of the convention and the direction for the way insulin's used in combination these days. So as I mentioned just a moment ago, the injections can vary from 1 to 4 during the day, depending on what type of insulin the patient's using and how they're using it. There may be, as I mentioned, commonly right now, you have a combination of short-acting and peakless. That's generally the goal. Sometimes patients will just be on an insulin pump, which just allows a continuous basal dose of a regular insulin, and then they give themselves a bolus through their pump to address correction coverage or carbohydrate coverage for a particular meal. Now, there are generally two approaches: a conventional approach, which has to do with subcutaneous injections, like I've talked about. An intensive approach would be an insulin pump, like I mentioned, where the patient is wearing a device that's constantly providing this basal dose of regular insulin. They're adjusting it based on what their sugars are and what their meal contains as far as carbohydrates go. So there's a constant throughout the day, very intensive approach. And then you can even go even more intensive than that, and that is when patients are in critical care and we're doing a regular insulin infusion IV, and we're monitoring sugars on an hourly or even 30 minutes sometimes basis. Very intensive approach there. Now, there are some side effects, some complications as a result of insulin therapy. So let's discuss some of these complications. One is a local allergic reaction. So there are preservatives and other components that are not insulin within this insulin, and that patients can react to those, and patients have been known to react to insulins. It's less common than it used to be because our insulins do not come from replication of other animals' DNA. Insulin from animals, it comes from replication in a lab. So fewer allergic reactions these days, but that can happen, and definitely systemic allergic reactions are less common. That used to happen when we were using pig and horse insulin back in the day. A side effect that happens, a complication, is lipodystrophy, and this is more common when patients do not rotate their sites. So if patients are not rotating their injection sites, injecting in the same place every time, then that tissue, the subcutaneous tissue there, that adipose tissue, begins to break down. And the result of that is, yes, it's not appealing to look at. That's one consideration, but that's minor. The bigger issue is that tissue doesn't absorb insulin and distribute it as efficiently as it did before, and perhaps not at all. So for this reason, we encourage patients to rotate sites, rotating to the abdomen because it's a very large area with some degree of regularity, but again, not the same place in the abdomen. You have a large surface area there to inject over the abdominal wall, and then rotate with the legs or the arms to kind of rotate off those sites. So all of those are possible places for site rotation to prevent this lipodystrophy. Now, also patients can develop resistance to injected insulin. Does happen, it's less common. In that case, may have to change to alternate types of insulin or offer alternate delivery methods. Now, one of the things that the book mentions but doesn't discuss is morning hyperglycemia, which they basically say this is not well understood, but I like to provide this image here to show you that in some ways it does somewhat make sense. So what you have here is a illustration of when cortisol peaks. Remember, cortisol is a stress hormone, and it usually peaks somewhere between 4:30 to 7 in the morning. This is our normal circadian rhythm. When the cortisol level peaks somewhere around 6 o'clock in the morning, that's going to signal the liver to begin gluconeogenesis and glycogenolysis. Because what's happened here is the patient has been asleep all night, hasn't been consuming, so the cells sense an absence of carbohydrates, not because they're not in their bloodstream, but because the pancreas, one, is not making insulin, and if they're not on a peakless dose, they have no insulin in their bloodstream. So you have the absence of insulin, the presence of cortisol, and cellular need for energy. That sends a message to the liver to produce carbohydrates from fatty acid metabolism. So that's one of the reasons why you might have, a very logical reason why you might have morning hyperglycemia, even though they haven't had insulin through the night. So that kind of explains that rationale there. We have touched on some of this. This slide just lists for you some of the methods of insulin delivery, subcutaneous injections with which you guys are familiar. There are insulin pens out there. The insulin pens and injectors, these things are pricey, so you don't see those much. The insulin pens are very convenient. You dial in a dose and you inject, but again, they're very pricey. Now, insulin pumps are a different matter. Yes, they may be expensive and they may require some work. However, some of the companies that produce these pumps and produce insulin will work with patients who have financial difficulty. So there are patient assistance programs that help patients afford or acquire, sometimes even free of charge, insulin pumps, depending on patient need. So those are things that are out there along with the devices that help monitor. Now, these monitoring devices can be quite expensive, but again, some of these, there are some agencies and some of the companies that have patient assistance programs where you can, if there's a need there, you can petition for those. Some of the things that are on the horizon are ultimately implantable insulin pumps. One of the challenges there is there's going to have to be a reservoir, and that reservoir is going to have to be filled on occasion. So that's going to be a challenge to that part of the future. One thing I don't have listed here is some of the surgical procedures that are on the forefront. I'm pretty confident this is not going to be on NCLEX, and you're not going to be tested over it in this class. But they are doing things like cadaver pancreas transplantation. They're doing those things. They're doing what they call pseudopancreases, where they basically take intestinal tissues and make a pocket and fill that pocket with islets of Langerhans, those beta cells, and then implant that in abdomens. And what they're discovering, this is obviously an investigational work, but what they've discovered is that patients who have these actually start secreting those beta cells within that tissue will start secreting insulin again. So there's some optimism there in the future for possibly even getting patients basically a pseudopancreas that will enable them to be off of insulin as far as injections go. So we'll see where that goes as far as on the horizon. Now, one of the last things I want to discuss in this segment is educating patients in insulin self-management, and that's making sure they understand the use and action of insulin, what insulin's actually doing. And you have a slide about this, so I'm not going to repeat this. But they also need to be very well aware of the potential risks of hypoglycemia, that they have to be able to have an intervention handy, and that is that they may need to have some sugar packets that they keep in a backpack or in a purse. They may need to keep a snack handy, crackers and peanut butter. And they also need to be mindful of conditions that may trip them to get into a hyperglycemic cycle, and what they need to do when they have things such as a cold or the flu or some other form of virus, or as I mentioned before, like a urinary tract infection or something like that. What do they need to do? They need to be self-monitoring. They need to be consuming in some form. They're going to need calories in some form or fashion. If those are liquid calories, such as Pedialyte or something Ensure, whatever they're able to tolerate in those moments of illness, and discuss with their physician or their endocrinologist what sick day doses might look like in those kind of circumstances, so that they can avoid these severe hyperglycemic moments. And we've already discussed the importance of blood glucose monitoring and self-injection of insulin. And then there may also be a good deal of education. Should people start to use an insulin pump, we may have to walk them through that whole process. So there's multiple components and layers in an ongoing process for the education of these patients that are, first of all, diabetic, the type of diabetes they have, the medications we're using to manage, and the tools, the equipment that we're using perhaps to manage the insulin if they're on insulin. In our next section, we'll get into the acute complications of diabetes. We've kind of touched on that already, but we'll get into that next.